Actually, the first time I gave grand rounds here was when I was interviewing for the job to head the Diabetes Center, and it was actually on the just then published DCCT trial. So it was a long time ago. So this is a study whose conclusions are much less straightforward than the DCCT trial, but whose impact, in fact, may turn out to be greater. The topic overall is really about the relationship of glycemia and cardiovascular disease, but specifically not the epidemiology of glycemia and cardiovascular disease, where there's a relatively straightforward relationship, but the issue of treatment targets and cardiovascular disease. The American Diabetes Association, the American College of Endocrinology have both opined about what they think reasonable treatment targets are in diabetes. All these recommendations, no matter who generates them, are based exclusively on data regarding microvascular complications, the eye, kidney, and nerve disease that affects patients with diabetes, and not based on cardiovascular disease, which in fact kills about 80% of people with diabetes. Actually, the American Diabetes Association is the only international, or actually national or international organization that has recommended an A1C target of less than 7%. Every other organization in the world has actually gone beyond that recommendation and recommended that we aim for treatment targets of less than 6.5%, despite the fact that no clinical trial until ACCORD had ever gotten to an A1C of 6.5%. For studies that lasted more than a few months' duration. At the time when the ACCORD trial was being designed, there were data available regarding cardiovascular endpoints in trials that compared different strategies of glucose lowering. So the UKPDS trial we'll come back to in a moment. It was a trial involving new onset patients with diabetes. The Kumamoto trial was a trial very analogously designed to the DCCT trial, but it involved patients with type 2 diabetes in Japan that could have absolutely no cardiovascular risk factors. So they couldn't be overweight, they couldn't be hypertensive, they couldn't be dyslipidemic. One would wonder how they found patients for this trial in Japan and whether they really did have type 2 diabetes. The VA cooperative study for diabetes was a pilot study for the VA diabetes trial that I'll mention in a moment. It was quite short, just 2.3 years. It was not at all designed to look at cardiovascular endpoints, but certainly examined cardiovascular safety. And then the UGDP study is an ancient study in which patients were randomized to fenformin, the previous biguanide that's no longer available in the United States, tolbutamide, a sulfonylurea that's no longer used in the United States, insulin or no care. And the initial publications were actually in the 1970s. All of these studies suggested that with glucose lowering, there was a modest reduction in cardiovascular endpoints, other than a sub-randomization within the UKPDS study, where well into the study, when they were worried about the separation between the two arms, they created a new sub-study where patients who were treated with sulfonylurea could be randomized to the early addition of metformin or to just continue on sulfonylurea. So that relatively short study actually had a nearly 100% increase in cardiovascular endpoints. And the VA cooperative study, another relatively short study, had a 40% increase in cardiovascular endpoints. Now, there were 3 trials that were designed and initiated more or less simultaneously around the world. The ACCORD and ADVANCE trial were both very large studies, over 10,000 patients. ACCORD conducted in the United States and Canada, and the ADVANCE study mostly in Asia. It was coordinated out of Australia, so sort of the Pacific regions, Asia, India, Australia, New Zealand, Africa. And the VA diabetes trial was a smaller study conducted exclusively in VA centers across the country. ACCORD and VA were both very intensive interventions, and the reason for that is that these patients had relatively high A1Cs, 8.3% and 9.4%, despite pretty good faith efforts at glucose lowering already at baseline. So 34% of the ACCORD patients and 51% of the VA patients were already on insulin, generally in addition to oral agents at baseline. And we're on a substantial number of oral agents as well. And both the ACCORD and the VA trial aim for an A1C target of less than 6% in their intensive arm. So here they were looking for a 2.3% reduction in A1C in some patients that have been relatively intensively treated already, and here a 3.4% reduction in A1C. The ADVANCE trial was sort of a mellower study. This patient population had an A1C of 7.5% at baseline. Essentially, none of them were on insulin at baseline. And the intervention really amounted to randomization to a sulfonylurea or not. And then there was some additional efforts later on in the trial to achieve a greater separation by using insulin and glitazones more intensively in the intensive group. But in any case, not so many patients in the ADVANCE trial ended up on insulin or glitazones, whereas in the ACCORD and VA trial, essentially all the patients that were in the intensive arm were treated with both. The endpoints for ACCORD and ADVANCE were the standard, MI, stroke, cardiovascular death. The VA trial, having a much smaller patient population, required a much broader set of endpoints to have enough endpoints to have any hope of reaching statistical significance. What you can see for the primary outcome is that none of the trials reached the were statistically significant with regards to reduction of the primary endpoint. The ACCORD group, in collaboration with these groups and UKPDS, is working on a meta-analysis. The final I's haven't been dotted and the T's haven't been crossed. To be honest, any of you could work with someone in the School of Public Health and do a meta-analysis if you wanted to. The Mind's Eye meta-analysis suggests about a 10% reduction in risk overall, and it is in fact extremely likely that that would be statistically significant if you went to the trouble of doing that meta-analysis. With regards to mortality, which was the big story when these trials were released, the ACCORD study demonstrated a 22% increase in total mortality, a somewhat higher increase in cardiovascular mortality. The VA trial, the point estimate was that there was excess mortality in the intensively treated group, and cardiovascular mortality was a 22% increase, neither of those being statistically significant. ADVANCE didn't show any trend towards an increase in mortality. And again, ACCORD and VA were the two really intensive programs. ADVANCE, the mellower intervention. Now there's an asterisk here and a p-value that's provided here of 0.04. To be honest, this was something that was included in the manuscript at the insistence of the reviewers. The ACCORD investigators felt that it wasn't really legitimate to provide a p-value here because this was a safety measure that was looked at repeatedly by the Data Safety Monitoring Board, and the study was stopped, or this glycemia intervention was stopped at a point in time based on their observation of the hazard ratio for mortality. And so this is the raw p-value that hasn't been corrected for the number of looks at the data. Now, some optimists have looked at the Kaplan-Meier curves with regards to the risk of heart attack, stroke, and cardiovascular death, and said, well, there's this emerging benefit in the ACCORD study after 4 years. And I think you could hallucinate that as a possibility, but that would be a very post hoc kind of analysis. And then the most extreme optimists will look at the ADVANCE trial and say, well, it's actually after 60 months where this benefit emerges. Again, I think that would be a very optimistic worldview. There were protocol-defined subgroups within ACCORD, and in the analysis plan, a plan to look at the potential interaction of baseline characteristics with the outcomes of the study. And what was demonstrated in ACCORD was that the primary prevention group, the people that had no known vascular disease at the beginning, did seem to have a greater benefit from the intervention than the secondary prevention group. And those patients who had a baseline A1C less than 8% likewise seemed to have a greater benefit from the intervention than the patients with an A1C of greater than 8%. In the ADVANCE trial, these were their pre-specified subgroups for a similar kind of analysis, and the only one where there was a suggestion of difference was patients with pre-existing macrovascular disease. There are two analyses that were not included in the VA diabetes trial paper that were presented at the American Diabetes Association meeting a year ago that are interesting. One was in a subgroup within the VA trial at 6 of the VAs. They did coronary artery calcium scoring at the beginning of the trial and looked at coronary artery calcium score is a predictor with regards to cardiovascular endpoints and the benefit of the intensive versus standard intervention. And what was shown in this sub-study of the VA diabetes trial is that there really wasn't any hint of benefit. There wasn't any hint of benefit in the patients with the higher coronary artery calcium scores, but a substantial signal for benefit with regards to the patients with the lower coronary artery calcium scores. So, something analogous to the observation in ACCORD in ADVANCE that the primary prevention group may have greater benefit than the secondary intervention group. They also had another analysis that was not included in the final manuscript, and it's not at all clear why it wasn't. There is a statement in the paper that they only included the pre-specified analyses in this paper, so this is something that may come out later, or it may be something that with further analysis it went away. But the idea was that there seemed to be benefit in the VA diabetes trial for patients who had a shorter duration of diabetes before they entered the study, and more of a signal for harm in patients who had a longer duration of diabetes at the beginning of the study. We did exactly this analysis in ACCORD and could not come up with that relationship. There are two other studies that I think are relevant to the discussion of what should our goals of therapy be in diabetes, and particularly in relation to cardiovascular disease. And the first is the DCCT follow-up study, which is called EDIC. So the DCCT was a trial that involved relatively recent onset patients with type 1 diabetes. I think the average duration was 6 years. The average age at the beginning of the trial was in the mid-30s. Patients were randomized to an intensive program of insulin administration involving lots of face time with diabetes educators and dietitians and behavioral therapists and exercise physiologists. They were seeing these people every month. And they were actually talking to them on the phone every week for a period of about 6 years of average follow-up. At the end of the randomized portion of the trial, it had been demonstrated that intensive therapy was associated with a reduction in all microvascular endpoints. The conventional group was encouraged to switch to intensive treatment. The intensive treatment group was encouraged to continue with their intensive treatment, but both were liberated into the community where they didn't have nearly the level of support that they had in the study, and both groups ended up with an A1C of about 8 to 8.3%, with really no difference between the two. That cohort is still being followed, but after 10 years of additional follow-up, what was demonstrated was a 42% reduction in this large concatenation of cardiovascular endpoints: MI, stroke, death from cardiovascular disease, confirmed angina or the need for coronary artery revascularization. This was an endpoint that was pre-specified in the 1980s when the trial was started, and the endpoint was analyzed when a certain number of events had been reached. There is another analysis that's been presented on just fatal MI, stroke, or cardiovascular death, and there the reduction is 57%. Let's see, previous. So this effect has been termed metabolic memory. And when it was first, hypothesized that this metabolic memory exists, the proposal was that, particularly with protein glycation, they are very stable proteins in the body, particularly matrix proteins that have half-lives of years, if not decades, and that it would certainly be possible that these advanced glycosylation end products would form on these matrix proteins and continue to influence the pathophysiology of atherogenesis for years or decades later. But I think it's important to remember there's a lot more differences between the conventional treatment group and the intensive treatment group than A1C for 6 years of the randomized portion of the trial. The intensive treatment group got a lot more nutrition input. They got a lot more exercise physiology input. They got a lot more behavioral input. So there may be behavioral differences or nutritional differences or exercise differences between these two arms that are not adequately accounted for in the analysis. But the UK-PDS study also demonstrated a similar effect. So the randomized portion of the trial was 10 years of average follow-up with 10 additional years of follow-up without a real treatment difference between the two arms. The percent risk reduction that was observed for all of the aggregate endpoints, including myocardial infarction and all-cause mortality, the percent benefit was maintained for 10 years after the randomized portion of the trial. More events were accumulated, and so now myocardial infarction and all-cause mortality is statistically significant with about a 15% reduction in each. The surprise, which is analogous to the DCCT surprise, is that apparently the benefit of this more intensive intervention persists over a long period of time. Now, the British, being British, had to call this similar effect something different, so they called it the legacy effect. And the most interesting thing about the legacy effect as it pertains to the UK-PDS study is there was also a blood pressure randomization in the UK-PDS study, and in the analysis of the blood pressure randomization, there is no legacy effect, which does, for me, make me a little bit more of a believer that maybe it really is glycemia that's the difference between the two arms and a persistent benefit over time. So the new hypothesis, which granted is nothing but a hypothesis, is that poor glucose control is associated with a buildup of bad metabolic memory, which drive the risk of future development of complications. And a corollary to that hypothesis is that when we first diagnose diabetes, there may be an advantage to treating diabetes relatively aggressively in the beginning, when it's relatively easy to do, and take it easier on patients later in the course of the disease when achieving and maintaining A1C levels less than 7% is much more difficult and associated with more adverse events like hypoglycemia and weight gain, et cetera. So to deal with those 5 studies, ACCORD, ADVANCE, the VA diabetes trial, the DCCT extension called EDIC, and the UK-PDS extension, the American Diabetes Association, the American Heart Association, the American College of Cardiology got together. And that's a pretty amazing thing in and of itself. So these organizations compete on many levels for many different things. It's been a historic event when any 2 of these organizations have gotten together and said something with a communal voice. It really reflects the fact that there was some panic and certainly a lot of mayhem in the community in dealing with the results of these trials. So the 3 organizations got together and agreed, and it's really a very interesting document to read if you have a half an hour or 45 minutes. But the concluding bullet points are that with regards to glycemic control recommendations, that an A1C target of less than 7 has been demonstrated to reduce the microvascular and neuropathic complications in type 1 diabetes in the DCCT trial, in type 2 diabetes in the UK-PDS study, and therefore for microvascular disease prevention, the A1C goal for non-pregnant adults in general should be less than 7%. The second bullet point is that based on long-term follow-up of the DCCT and UK-PDS studies, these extension phases that I showed you, it suggests that treatment to A1C targets below or around 7% in the years soon after the diagnosis of diabetes is associated with long-term reduction in the risk of macrovascular disease. Until more evidence becomes available, the general goal of less than 7% appears reasonable for many adults for macrovascular risk reduction. The third bullet point deals with subgroup analyses from the DCCT and UK-PDS that I haven't shown you, and the microvascular evidence from the ADVANCE trial, which I also didn't show you. In that study, they showed a small improvement in the risk of albuminuria and the progression of albuminuria in the ADVANCE trial with the A1C of 6.4 versus about 7.3. But anyway, the suggestion that there's a small is the important word there, but incremental benefit in microvascular outcomes with A1C values closer to normal. Therefore, for selected individual patients, providers might reasonably suggest even lower A1C goals than the general goal of less than 7%, if this can be achieved without significant hypoglycemia or other adverse effects of treatment. Such patients might include those with short duration of diabetes, long life expectancy, and no significant cardiovascular disease. So at Accord, we got a lot of correspondence after, from people, literally patients all over the world concerned about our results, where the patients that had an A1C of 6.3% had an increased risk of mortality versus those that had an A1C of about 7.5%. And one of the letters that was really, most surprising was a guy who had lost a bunch of weight, and his A1C at presentation had been something like 6.9%, and he had developed a lifestyle program, and his A1C was now 5.5%, and he was actually concerned that he could have done himself harm by having this excellent level of blood sugar control. So, I do think that this is an important message, but I do think it's very important. These words were selected very, very carefully, that the benefits of lower targets are small, though incremental in the studies in which they've been examined. And it is important that that the patients, really tolerate these therapies very, very well for them to even be reasonably considered. And I do think that it would be unreasonable in patients who have, 10 or 20 years of diabetes, or they're in their 70s or 80s, or who have advanced complications. And then the most controversial of the bullet points is, conversely, less stringent A1C goals than the general goal of less than 7% may be appropriate for patients with a history of severe hypoglycemia, limited life expectancy, advanced microvascular or macrovascular complications, extensive comorbid conditions, and those with long-standing diabetes in whom the general goal is difficult to attain despite diabetes self-management education, appropriate glucose monitoring, and effective doses of multiple glucose-lowering agents, including insulin. Now, this is basically, the population at Highgate in our diabetes center. This, I'm sure, is basically the population in the general medicine clinic. This is even a little bit further down the line than the population in cardiology or nephrology clinic. So this is a large number of people where the advice of 3 organizations, as well as me, is to really be very careful about the way that you flog these patients to get their A1C down. So if you can achieve an A1C of less than 7 relatively, with moderate effort, and if the patient is tolerating those therapies well, fabulous. If they're not tolerating the therapy well, or if it's really consuming a lot of your time and effort, it's something that probably needs to be thought about just for a bit, because there are other ways of preventing cardiovascular disease for which the evidence base is much stronger. So what happened in the Accord study and the VA diabetes trial to cause increased mortality? Well, the first point that I want to make, it's not absolutely 100% positively certain that increased, more intensive therapy is associated with a greater risk of mortality. I mean, there's some statistical issues here, but I'm willing to take it as a given. I think the leading hypothesis is that perhaps hypoglycemia, particularly in patients with cardiac autonomic neuropathy, where it's been demonstrated that hypoglycemia can cause ST segment changes, can cause myocardial infarction, can cause uncontrolled hypertension. That could be a pathway that could explain this difference. That said, these studies have done very careful analyses, and it turns out that severe hypoglycemia in the patients in the standard group was much more associated with the risk of mortality than in the intensive group. So there's not a straightforward relationship in these trials with hypoglycemia and mortality. Rosiglitazone has been suggested that it may be associated with an increase in cardiovascular risk. There are long-standing hypotheses that hyperinsulinemia could drive cardiovascular risk, and that sulfonylureas actually work on an ATP-dependent potassium channel that could increase the risk of ventricular arrhythmia in the setting of ischemia. That said, in the analysis in the ACCORD and the VA trial to date, there doesn't seem to be any association with rosiglitazone, insulin, or sulfonylurea, or the combination of any two of the three, or the dose. So we've flogged this pretty hard, and we can't come up with any evidence. Weight gain is something that we, to be honest, have not been as successful from a statistical point of view of doing this analysis, because the weight gain is so confounded with the drug therapies and the randomization that it's just hard to pull out what the effect of weight gain is versus everything else. So that's still a hypothesis that I would say hasn't really been excluded to the best of our ability. There is a hypothesis that really the problem in the ACCORD and VA trial is that the A1C dropped too fast, because in the advanced trial, where it dropped very slowly, there wasn't the same difference. But some subsequent analyses in the ACCORD show that in fact, if your A1C drops fast in the beginning of the trial, your chance of death is actually reduced. You actually have a benefit with regards to death as an endpoint. The actual A1C target achieved, likewise, doesn't seem to be the association. If your A1C is less than 6 in the intensive arm, you actually have the best outcome in the study. The people who have the worst outcome in the study are actually the people in the standard arm who had no business getting their A1C less than 6, who got their A1C less than 6. So there is no straightforward relationship with A1C. I showed you the data about the more advanced disease, but the hypothesis that I personally I'm drawn to is that we really broke the hearts of these people in the intensive group. And I want to explain to you what I mean by that. So in this trial, patients were being seen every 2 months, and they would get a phone call in between. In the beginning, they were all gung-ho. Actually, to be honest, they were all on the fence about which arm they wanted to be in. I mean, some would say, I want to be in the intensive arm, or some would say, well, I don't want to be in the intensive arm. But they were willing to do the job. And so after 4 to 6 months, 2 or 3 visits and a handful of phone calls, most of them are now on metformin and a sulfonylurea and a glitazone, and often multiple daily injections of insulin, but at least insulin. And then for the next 5 years, we are seeing them every 2 months and seeing their blood sugars at least monthly, sometimes even every 2 weeks. And if they don't have more than 50% of their blood sugars under 100 and an A1C less than 6%, and most of their 2-hour postprandial glucose is less than 140, we have to advance their therapy. And I just wonder what the psychological and emotional effect is of taking people who are middle-aged and older, who have a fair burden of illness, that are working really hard at controlling their diabetes, and just relentlessly, month after month after month, saying, this isn't good enough, you have to increase your insulin. This isn't good enough, you have to increase your insulin. So I think that was the ACCORD effect. The VA actually was probably worse as far as the intensity of the intervention. So, I kind of reviewed where the ADA is with regards to the targets. I participated in that group. I actually think it's pretty good advice. Some people have gone a little bit farther to say that perhaps the target should be in people with advanced disease, with heart disease, should be to get the A1C at least under 8. So in the standard arm of ACCORD, that was the target for the standard arm, to have an A1C between 7 and 8. And maybe that's reasonable as sort of an additional detail. But I want to turn now to discussing, how do I think we should think about getting to those targets? First, there are recommendations from the ADA about screening for diabetes, and I don't want to go through them in detail. Basically, it's everybody over the age of 45 and people under the age of 45 who are overweight and have another risk factor for diabetes. There will be new recommendations in the very near future from the ADA about this. It's going to get a little bit simpler. The list won't be quite as long. The screening cut points are that a glucose of 99 or less in the fasting state would be normal, that 126 or higher would be diabetes. In general, the ADA doesn't recommend doing glucose tolerance testing. It's more sensitive, but certainly much more of a burden on patients with diabetes. And then particularly in the pre-diabetes arena, the glucose tolerance test is a very skittish test. So if you do the test on 2 separate days, there's a 40% chance that an abnormal test would turn into a normal test just on repeat. So we don't generally recommend doing the glucose tolerance test. The risk of progression to diabetes in people who have these pre-diabetic conditions is on the order of about 10% per year, higher for the people with impaired glucose tolerance than the people with impaired fasting glucose. And another specific bit of the language in these guidelines is that A1C is not accepted as a diagnostic test for diabetes due to lack of standardization and suboptimal sensitivity. We'll get back to that in a second. It's recommended that people who have any form of prediabetes, and frankly, one could argue, people that are overweight or who have hypertension or who have dyslipidemia, there's a general recommendation that lifestyle intervention is reasonable in such populations. And the lifestyle intervention that has been shown to work in preventing the progression to diabetes is balanced low-calorie nutrition. So the studies that have worked have involved low-fat diets where there's specific counseling to increase high-fiber foods, vegetables, fruits, and whole grains. They've all involved regular physical activity, both aerobic and resistance training. And perhaps the most important feature of these effective interventions is frequent intervention with dietitians and lifestyle coaches. So all the studies have had weekly intervention for the first month, monthly for the first 3 months, and every 3 months for life. One of the studies, it was all done as group therapy work. Nothing, no individual counseling at all. And that's something that could be cost effective, I think. The kind of therapy that was done in the studies is very, very expensive, highly medicalized, and not covered as a benefit in any insurance plan for people with prediabetes. So the current recommendation of the ADA is to screen for diabetes using generally the fasting plasma glucose test. If it's normal, to repeat that screening test in 3 years if the risk factors remain. If they have impaired fasting glucose or glucose between 100 and 125, to recommend this lifestyle intervention, and that they need medical follow-up in a year. They should have an A1C, blood pressure, lipids, that sort of thing, but not, the idea of this lifestyle intervention would be a community-based program with fairly continuous involvement of the patient in such a program. For people who have both impaired fasting glucose and impaired glucose tolerance and other features, age less than 60 and BMI greater than 30 being the most important of those, there is now a recommendation that you consider using metformin therapy even in the setting of prediabetes based on the results of the diabetes prevention program. And I won't go over that with you, but that's the recommendation. The recommendation actually is lifestyle intervention and or metformin. Many people say, well, why would it be or metformin? And the reason, again, is these lifestyle interventions that are effective are not covered and very expensive. And so if people didn't have access to a community-based lifestyle program, metformin might actually be the cheaper way to go. And for people less than the age of 60 and with a BMI greater than 30, it is more or less as effective as lifestyle therapy. And that for patients with diabetes, the recommendation is lifestyle plus metformin and then follow up every 3 months. So, as kind of a diversion, I want to point out that when you measure glucose to screen for diabetes, you need to recognize that glucose is not a standardized analyte. So there is something called a CAP survey, the College of American Pathologists. And to get a laboratory certified, they send blinded samples several times a year. You run it on your machine. You write down the result of the assay. You send it back to the College of American Pathologists, and a few months later they say, you're certified to measure this analyte on that machine or not. Now, how they decide whether you're certified is not based on a comparison of the glucose value that you got compared to everybody else in the world. It's the comparison of the glucose value you got on that machine versus other people who use that machine. So if you take the highest biased value that's acceptable, which would be basically within 12 milligrams per deciliter or 20% from the mean value, so the highest biased sample that's from the highest biased assay compared to the lowest biased sample from the lowest biased assay, there's about a 30% swing in the glucose value that you could get in one clinic versus another. And I think very few people recognize that. Now, the truth of the matter is most assays are better than that, but the worst assays are really bad. And that compares to about a 5% difference for other analytes. Now, over the last 15 years, we've done a lot of work to standardize the hemoglobin A1C assay. So you can see that, 15 years ago when I was thinking about interviewing here at UNC, hemoglobin A1C was just a mess. The result that you would get in one hospital versus another hospital, the spread was enormous. Nowadays, hemoglobin A1C is actually a highly standardized analyte. There's an international standard that's used as a reference in every assay in the world that started in 2007. It's a much more reproducible assay. The second thing is that it's been known for a while that fasting glucose, 2-hour post-challenge glucose, and hemoglobin A1C all reasonably well predict the future risk of retinopathy. And hemoglobin A1C has some, at face value advantages versus fasting plasma glucose and the glucose tolerance test as a way of predicting the future development of diabetes. First, it's standardized. Second, it's an index of overall glycemic exposure. And so there are people who have elevated fasting glucose, but no elevation in the glucose tolerance test. And there are people who have elevated glucose tolerance test results, but no elevation in fasting glucose. Hemoglobin A1C tends to pick up on both of those abnormalities. It's equivalent and maybe even slightly superior in predicting the risk for long-term complications in the biggest studies. It also predicts cardiovascular disease, which fasting glucose and 2-hour post-challenge glucose do less well. There's less between laboratory variation, and then there's this pre-analytic instability, which is if I draw a tube of blood and put it on my desktop for a week, the results will not change much for hemoglobin A1C. But for glucose, if I draw a tube of blood and I put it on my desktop even for a half an hour or an hour, the glucose levels will fall as glycolytic enzymes within the tube start to chew up the glucose in the tube. So there's a lot of issues that can make a difference in glucose measurement. And most importantly, doesn't have to be a fasting or time sample, and it's unaffected by acute perturbations in glucose levels related to stress or illness. And lastly, an advantage would be, theoretically, if we use the hemoglobin A1C as the screening and diagnostic test, we would be able to use the same test to make a diagnosis and then follow up people over time, like we do with cholesterol or blood pressure or most other things in life. It has its limitations. It's expensive, so it's about 10 times more expensive on the cost end of things in the laboratory to measure. The charge, what's reimbursed is about twice as high. There are patient-related factors that can cause false negatives and false positive, particularly hemoglobinopathies and conditions that are associated with variations in red cell lifespan. It's a little bit unclear. There may be some ethnic differences. Caucasians may have a relatively lower A1C for a given level of glucose. That's a little bit unclear, to be honest. The elderly likewise may have a little bit higher A1C for a given level of glucose. And then in thinking about changing the diagnostic criteria for diabetes, what would be the rationale for doing that? It's absolutely clear that if we now have 3 ways to diagnose diabetes: fasting glucose, glucose tolerance test, and A1C, that there will be many patients who are positive for 1 of the 3 or 2 of the 3, but not all 3 of the 3. If we said if you could have or, meaning you could have a level above a certain level for fasting glucose, oral glucose tolerance test, or A1C, would dramatically increase the number of people with diabetes. Likewise, if we said and, where you had to have all 3, it would make things more complicated and also dramatically lower the number of people with diabetes in America. But in any case, the old recommendation was to make the diagnosis of diabetes by screening, to treat patients with lifestyle and metformin. If that wasn't enough, to add insulin, sulfonylurea, or aglitazone. And if that second step of therapy wasn't enough, to mix and match these things until you're basically using high doses of all 4. Those drugs were selected because they're very active glucose-lowering agents, and they have an outcome study suggesting benefits associated with them. But since the original algorithm was published, we had the rosiglitazone Nissen meta-analysis suggesting that rosiglitazone might be associated with increased cardiovascular risk, and then a bunch of meta-analyses after that. We had, with pioglitazone meta-analyses, that suggested, if anything, there were benefits, and we did have the PROACTIVE study, which statistically had its issues, but at least suggested trends towards benefit with regards to cardiovascular endpoints. And lastly, we had new emerging data that glitazones were associated with an increased risk of fractures, and this is true for both rosiglitazone and pioglitazone. The absolute increased risk of fractures is on the order of about 1%, at least in postmenopausal women. And the other thing that's happened is we have this relentless release of more drugs in the diabetes space. So my guess is that these drugs that are not on the algorithm, that half of you don't even know, you couldn't name a GLP-1 agonist or a DPP-4 inhibitor or a bile acid sequestrant that was approved for the use in diabetes to lower glucose, or bromocriptine, which was approved by the FDA yesterday for the treatment of diabetes. So, there's been huge developments in the diabetes field, and every one of these companies and, key opinion leaders that work for these companies, have been agitating with the ADA, well, you need to put our drug on your algorithm. You need to put, this drug on the algorithm. The most heat was around the area of GLP-1 agonists and DPP-4 inhibitors, and for those of you that don't know that much about it, so GLP-1 agonist, that's exenatide, is the only one available now, and sitagliptin is the DPP-4 inhibitor. There are investigational agents of the exenatide group that last more than 24 hours. Exenatide provides about a 1% lowering of A1C with about a 3% to 5% loss in body weight and an improvement in cardiovascular risk factors associated with that weight loss. It's injected twice a day, timed with meals, not the most convenient drug to take. Sitagliptin is very easy to take, very well tolerated, but pretty modest in its glucose lowering capacity. It's about a 0.7% lowering in A1C. Doesn't provide for any weight loss, it doesn't do anything except lower glucose a bit. Now, there may be other things that it does, and it does some really wonderful things in mice and rats. It just hasn't been shown to do those things in humans yet. And these investigational agents are associated with the same weight loss as exenatide, but much greater efficacy with regards to A1C lowering, is generally better tolerated and can be administered either once a day or once a week. And there are old data that people with diabetes who lose weight actually do have improvements in cardiovascular endpoints. So some people really glommed onto the idea that diabetes drugs that were associated with weight loss might be the way to go, at least in a world where we have questions about insulin, sulfonylurea, metformin, and glitazones based on studies like ACCORD Advance in the VA diabetes trial. So the new algorithm suggests that, again, you would start with lifestyle therapy and metformin when you make the diagnosis of diabetes. that if that wasn't enough, that there are 4 acceptable second-step agents, adding basal insulin, adding a sulfonylurea with a caveat not to use glyburide or chlorpropamide. We could talk about that if you want. That you could think about using pioglitazone, but not rosiglitazone, and that you could think about using a GLP-1 agonist. That would currently be exenatide, though those words were chosen very carefully, recognizing that these newer agents with longer half-lives may have greater benefit. These therapies, pioglitazone and GLP-1 agonists, have been termed less well-validated therapies because we don't have outcome studies, with a positive endpoint here. Why would you even think about using less well-validated therapies? The idea is, or what's said is, in patients where hypoglycemia was a major consideration, which should be for people who drive for a living or operate heavy machinery and that sort of thing. And for people where weight gain is a major issue, where you would think specifically about GLP-1 agonists. There are also new recommendations regarding lipid targets that I'll just mention. They have not been widely adopted. It's being evaluated in the so-called NCEP4 process. But the recommendation is that for most people with diabetes, which would be those with known CVD, people with diabetes and one more additional major cardiovascular risk factor, smoking, hypertension, or a family history of premature coronary disease, that the LDL target would be less than 70. The non-HDL target, maybe even more important, should be less than 100, and considering measuring ApoB as well. Aspirin is being evaluated by a working group that's actually headed up by Mike Pignoni, and maybe they have an answer already, I don't even know. There have been a couple of trials that have called into question the benefit of aspirin in primary prevention in diabetes. Well, I don't know what the answer is, but maybe Mike does. And then the last point that I make is that over the last 5 or 6 years, we've done much, much better in controlling glucose. So I'm a little bit concerned that these negative studies actually may cause us to backslide a bit in these areas. I don't think that patients are getting to A1Cs less than 7 in America by getting flogged in the Accord VA diabetes trial fashion. I think it's mostly because we're making the diagnosis of diabetes earlier. So it used to be that 50% of people with diabetes were undiagnosed in America. Now it's about 25%. So we've had about a 50% increase in the proportion of patients with an A1C under 7. We've had about a 50% decrease in the proportion of patients with an A1C over 9. We're improving in blood pressure and lipids. The STENO2 trial suggested that both in the randomized portion of the trial and the long-term follow-up, that the big payoff is actually when you take care of blood pressure and lipids and A1C in the same patients with, on the order of 50% reductions in endpoints. The Accord investigators love to point out that, if the DSMB here had been as vigilant as the Accord DSMB, maybe the STENO2 trial would have been stopped early because they also had an increase in mortality in the first 4 years of the study. But, the biggest message I have is that for people who practice medicine at UNC, UNC was one of 30 academic medical centers that participated in this study where we looked at how likely was it that a physician would increase the dose of medication or start a new medication in patients with diabetes. And this was done in the endocrine clinic, the family practice clinic, and the general medicine clinic. If their A1C was greater than 7, greater than 8, or greater than 9, it's about 40 to 50% of patients had a dose increase or a new dose drug added, which you might say, well, that's terrible. It should be much higher than that. I'd say, well, that's pretty good. It's always something to be said about thinking about it for a few months and encourage people to be more adherent with their old therapies and perhaps re-intensify their lifestyle therapy. So I thought 40 to 50% was pretty good. But if you look at people with elevated blood pressures, even greater than 150 or over 100, or LDL greater than 160, less than 1 in 5 of those patients had their therapy intensified or advanced. So, we need to pay at least as much attention to blood pressure and lipids in diabetes as glucose. So thank you very much for listening. I'd be happy to answer questions if you have any. while I was putting these slides together, I just knew that Norton Hadler would be sitting right there with the first question.
It's an obvious question. In the spirit of informed medical decision-making, you have a 45-year-old patient who's junkie and doing your lifestyle thing. And you're about to step onto one of your algorithms. And before you do, that patient says, before I let you do this algorithm, what is the likelihood you'll do me harm, and what is the likelihood you'll do me important good, not surrogate measure, but important good? Tell me, if you took 100 patients like me and you gave me your algorithm for the next 20 years, how many of them would be dead because of your algorithm, and how many of them would have a really important outcome that they would say, thank you for saving my heart, my brain, end-stage renal disease, my foot, something important in the course of 20 years?
Right. So, well, in the UK PDS study, which I showed you the data, death, which I think is a pretty reasonable endpoint, seemed to be 15% reduction in mortality. They didn't put it in terms like this, you live this much longer because of this reduced mortality. But this is an extension phase. The only, right, exactly. Well, it was 10 years of randomized therapy. Right, exactly. But we're talking about a 45-year-old who's looking forward to 40 more years of life. But wait, right, exactly. It is a maybe thing. There is another analysis tool. It's called Archimedes. It's a model. It has been validated by predicting the outcome of 72 clinical trials. Granted, only 3 of them did it predict it before the trial was done, but was able to demonstrate the same results. But again, those trials are generally short-term trials. Archimedes suggests that the benefit with regards to life expectancy is on the order of 1 year of life, quality-adjusted life years, by doing this screening thing and intervention according to these algorithms. So the benefit on life expectancy is relatively modest. The cost per QALY in that kind of system right now is about $8,000. So it's $8,000 for 1 year. Yeah. So that's the best. Yeah, just like it's okay if you decide you don't want to get measles vaccine when you're 6 months old. You're free to make your decisions. Right. Quality adjusted life expectancy. It's not a bad year at the end. It's better times all along. And the cost is, I think modest, $8,000. I mean, I would pay $8,000 for a good year. Hell, I'd pay $80,000 for a good year. Oh no, we wouldn't recommend sticking your finger anymore. We have to bring you up to the 21st century with our recommendations. We don't recommend glucose monitoring except in insulin-treated patients. So that it's the other hope. But again, we don't have proof at all that with earlier treatment, perhaps we won't have to use as much insulin therapy down the line. But I would admit we have no proof at all there. Any other questions? Yes?
Blood insulin levels used at all in the group,
No, the question is about using blood insulin levels. Insulin is not a standardized analyte, so it's actually worse than glucose. And therefore, we don't recommend measuring it. Turns out that if you want that the predictive value for an individual of an insulin value being able to predict outcomes or who's going to respond to what kind of therapy is very, very poor for an individual. It works out pretty well for populations, but not for individuals. Oh, yeah. So the issue with glyburide, it's always been the sort of mantra at the ADA that in the absence of absolutely compelling evidence that there was a good drug and a bad drug, that for reasons of fairness, we always had to talk about classes of drugs. The issue with glyburide is there have been head-to-head studies between the sustained release formulation of glipizide and glimepiride versus glyburide that have shown a higher risk of hypoglycemia. They are extremely tortured in vitro systems that suggest that glyburide may have a greater effect on this cardiac channel that may have something important to do with the rhythm, the heart rhythm. And then in the UK-PDS study, glyburide was associated with a faster rate of secondary failure than even chlorpropamide. So it may be that glyburide is the bad actor. Certainly there's no evidence that glyburide does something special that's good. And so for that reason, we just dropped glyburide from the recommendations, mostly because of an increased risk of hypoglycemia. And the same, basically the same rationale was used with regards to rosiglitazone. Not that we have proof that rosiglitazone is associated with poor cardiovascular outcomes, really that rosiglitazone doesn't have the same benefits in lipid lowering as pioglitazone, and we don't have the proof that it's safe. The RECORD study, which hopefully will answer that question, will be presented on Friday, June 5th at 4 p.m. Thank you.